Hello students, till now we have examined we discussed about the symptoms of parabdominal system. Which are the symptoms we discussed? We discussed about abdominal pain, jaundice, ascites and GA bleed. Now let us go to the examination of abdominal system. First we will discuss the general physical examination. What all you will see in a parabdominal examination top to bottom. So first students, in the hair we have to see whether any lusterless or sparse hair is there in the head, you will see. The next coming down in the eyes. In the eyes, jaundice, as I already discussed, is a cardinal symptom as well as sign of an abdominal system examination. So you have to take ideally a patient to a bright light, ask him to patient to look downwards and then you have to look it. Okay? You have to lift the lid. मेरा उंगली देखिए, उंगली नीचे. You have to look him like that and see for the sclera. Okay. The other part which you can look is below the tongue and palate. You can look for a jaundice. What are the other things you look in the eyes in a case of abdominal system examination? KF ring. You have to look for KF ring because in a Wilson disease they can get hepatitis, acute chronic hepatitis they can get. You have to look for a KF ring. Then anemia, pallor, you have to look. So you have to look for a pallor in a case of abdominal system examination. Why you have to look for a pallor? What are the causes of pallor in a cirrhosis of liver? There can be hypersplenism producing pancytopenia. The alcohol itself has a bone marrow suppression action which can produce anemia. There can be hemolytic anemia due to Zeev syndrome in cirrhosis of liver, and you B12 deficiency you get in liver cirrhosis which can produce megaloblastic anemia. So you have to look for a pallor in the eyes. Pallor, icterus, KF ring. Then in the lower eyelid you have to look for xanthelasma. Xanthelasma is a feature of primary biliary cirrhosis due to hypercholesteremia. What are the other things you look in the face? Parotid gland enlargement. Parotid gland enlargement is a feature of alcoholic liver disease. So you have to look for parotid gland enlargement in alcoholic liver disease. Then what are the things you see in the mouth? Fetor hepaticus, because the mercaptans, okay, in a hepatic encephalopathy you will get a fetor hepaticus in the mouth. And then in the mouth, tongue, in B12 deficiency you may get a beefy red colored tongue. Then coming to the neck, in an abdominal system examination there can be in the liver cell failure there can be a lymphadenopathy. Left supraclavicular lymph nodes is known as Trojus sign, you see in GA malignancies and pelvic malignancies. Then coming to the thorax, you have to look for gynecomastia. How do you look for gynecomastia? You just palpate over the breast with your fingers gently. Okay? Gynecomastia is a feature of hyperestrogenism. Why hyperestrogenism occurs in liver cirrhosis? Because testosterone cannot be metabolized properly. It will be converted to dihydrotestosterone and that will be converted to estrogen peripherally. You have to look for other signs of hyperestrogenism. One is this gynecomastia. Other is any abscess, axillary hair or a pubic hair. You have to look for any axillary hairs. Okay. Then palmar erythema is another sign of hyperestrogenism. There will be a reddish patches. The palm will be palmar erythema. You can see palmar erythema. Then spider navy. Spider navy you see in the superior vena cava distribution. It is a central arteriole with radiating vessels. More than 5 is significant spider navies. What are the other things you see in the skin? Itching, pruritus marks, if it is there you will look for a pruritus itching marks. Tattooing marks, because tattooing can transmit hepatitis B, hepatitis C. So tattooing marks you have to see in the skin. Then in the hands, what are all the things you see apart from palmar erythema in an abdominal examination? Clubbing. Which are the abdominal diseases which produces clubbing? Inflammatory bowel diseases, hepatoma, primary biliary cirrhosis can produce clubbing. Leukonanchia, the whitish discoloration of the nail because of hypoalbuminemia. Dupuytren's contracture with the ulnar nerve, with the ring finger involving. Okay, the ring finger will be earliest to involve in Dupuytren's contracture. That is a feature of alcoholic liver disease. And one important thing is asterixes in a liver cell failure. How do you look for asterix? Ask the patient to hold the finger like this. Current, ऐसे hold करो. ठीक है. थोड़ा ऐसा. Ask him to hold the hand like that. If there is a flapping tremor, there will be a flap like this. That indicates hepatic encephalopathy. Then tylosis. Tylosis is thickening of the hands and the foot in CA esophagus. No abdominal examination is complete without the examination of scrotum. There will be a testicular atrophy in hepatic cell failure. So, of all the things which I discussed in general physical examination, the testicular atrophy, palmar erythema, spider navy, then gynecomastia is a feature of hyperestrogenism. Parotid gland enlargement and Dupuytren's contracture are highly specific for alcoholic liver disease. These are the general physical examination what you will do in a case of abdominal examination. Now let us go to the inspection, palpation, percussion and auscultation of the parabdomen. Before going for the inspection, palpation, percussion and auscultation, you have to divide the abdominal into quadrants, the 9 quadrants. The 10th quadrant is the scrotum. The quadrants are divided into 2 midclavicular lines will come like this, 2 midclavicular lines. This is the 2 vertical lines from the midclavicular, 2 vertical lines. Then 2 horizontal lines, one below the costal margin, transpyloric line like this, and another transtubercular line. Iliac tubercle it will join. So I repeat, 2 midclavicular line, 2 vertical lines. Then 2 horizontal line, transpyloric plane and transtubercular line. So now what are the areas it divides into? This is right hypochondric, epigastric, left hypochondric, left lumbar, left iliac, hypogastric or suprapubic, umbilical region, right iliac, right lumbar. I'll repeat. The areas are epigastric region, left hypochondric region, left lumbar, left iliac, suprapubic, umbilical, right hypochondric, right lumbar, right iliac. 10th quadrant is scrotum. Now, what are the things you see in an inspection of abdominal system? First is shape of the abdomen. The normal shape of the abdomen is scaphoid only. It will be very sunken in a malignancy emaciated people. Where you get diffuse distension of the abdomen. Diffuse distension, as I discussed yesterday, fluid, fat, feces, flatus, fetal growth. These are the causes of diffuse distension of the abdomen. Whereas a non-uniform distension you get in a tumors like ovarian cyst, any tumor from the pelvic region, you will get a splenomegaly, you will get a non-uniform distension of the abdomen. Only one side there will be enlargement. Next is umbilicus. Umbilicus normally is inverted and slightly retracted. You get a transversely stretched umbilicus in ascites, a vertical umbilicus, for example, if there is any tumors, ovarian cyst, it will put a vertical umbilicus. Transverse smiling umbilicus you get in ascites. Next is abdominal movement. See, normally the abdomen moves up and down. See, it is moving up, going down, moving up, going down. In which condition it doesn't move up and down? If there is peritonitis, the patient will keep the abdomen still. Abdomen doesn't move there. Then any striae marks, striae gravidarum, and then purple striae you may get in Cushing's disease. You have to look for distended veins. The ideal position to look for distended veins is in a standing position. So let us make him stand now and look for the distended veins. So you look for the distended veins in a standing position. If the distended veins are there on the flanks and back, it is Bucchiari syndrome. Around the umbilicus, you get in portal hypertension. Students, normally the flow of blood for normal person, it is away from the umbilicus like this. It is away from the umbilicus. Normally, it goes away from the umbilicus, even above and downwards, away from the umbilicus. But you can't see that. But in a portal hypertension, you can see that. You can see that the blood flow is away from the umbilicus in a portal hypertension. If there is a superior vena cava obstruction, the blood flow will be above downwards here also, above downwards here also, above downwards, above downwards. If it is an inferior vena cava obstruction, below upwards here also, below upwards here also, below upwards and below upwards. Understood? Normally flow is away from the umbilicus. Even in portal hypertension, same direction, but you can see it caput medicine. In a superior vena cava obstruction, the blood flow is above downwards here also, above downwards, above downwards. In inferior vena cava obstruction, below upwards, below upwards, below upwards, below upwards. Okay, students. Now you saw how to examine for the distended veins in standing position. The other thing you see in inspection is any visible gastric peristalsis, VGPs. The visible gastric peristalsis you get from left hypochondric and left in epigastric region and left hypochondric region. From that region, you can see the peristalsis till the right lumbar direction. Nowadays rare because pylorostenosis is very rare. Inspection, the other thing you can see is a Cullen sign and Gray Turner sign. In hemorrhagic pancreatitis, there can be a bluish discoloration surrounding the umbilicus, that is Cullen sign. Flanks, bluish discoloration surround in the flanks, Gray Turner sign. So these are the inspection things which you see. I repeat, the shape of the abdomen, umbilicus, movement with respiration, visible gastric peristalsis, striatum marks, distended veins, Cullen sign and Gray Turner sign. Next is palpation. Palpation students, you have to take some measurements. Normally abdominal girth you have to measure at the umbilicus level here, umbilicus level. In some conditions, in acute abdominal like peritonitis, intestinal obstruction, paralytic ileus, every day to monitor the prognosis. Then you have to measure the distance from epigastric region to the umbilicus, from umbilicus to the pubic symphysis. Normally the distance will be equal. Whereas umbilicus will move upwards if there is any ovarian tumors. It will move downwards if there is ascites. Then students, you have to measure the distance between anterior superior iliac spine and umbilicus, both the sides, anterior superior iliac spine and umbilicus, spino-umbilical distance. If one side it is more, that indicates that side there is a ovarian tumor, spino-umbilical distance. So first you have to take the measurements. Then the palpation of the abdomen. You have to rub your hands, ask the patient to turn toward the opposite side, breathe through the mouth. उस तरह मुंह से सांस ले, आराम से मुंह से सांस ले. So breathe through the mouth, rub your hands, then start from a left iliac fossa. It is a superficial palpation. You have to palpate superficially. Suppose if you find any abnormality in the superficial palpation, then from that region you have to start the deep palpation. For example, if you found in superficial palpation there is a problem in the left hypochondric region, then deep palpation you start from left hypochondric region. Okay, right. Now I'll teach how to palpate for some of the important organs in the abdomen. You should know how to palpate the liver, spleen, kidney, gallbladder, aorta. First let us go to the palpation of liver. So liver, I'll tell you three methods to palpate. One from the right iliac fossa, you have to palpate. With each expiration you move your hand. With each expiration you move your hand. With inspiration, if it is enlarged, it will come and touch. So this is one method. Again I repeat, from right iliac fossa you palpate. Moses asle. With inspiration, it will come and touch. If it is enlarged, this is one method. The other method is what Hutchison gives is with both the hands, you move upwards like this. With each expiration, you move your hand up. If it is enlarged, it will come and touch in the inspiration. This is the second method. The third method is in ascites. If there is a fluid accumulation, how do you palpate? If there is ascites, you will palpate by dipping method. You see, you will use both hands like this. With this hand, left hand you will dip the fluid, right hand you will palpate it. The left hand will displace the fluid like this, right hand will palpate it. Let us see how to do a dipping method. Dipping method, you give a sudden jerk like this. Sudden jerk like this. You will give a sudden jerk like this and you will palpate. The dipping method. These are three methods to palpate the liver. While palpating the liver, what you have to see is the border. The border will be round in heart failure and hepatitis, viral hepatitis or alcoholic hepatitis. The border will be smooth. The border will be sharp in cirrhosis, alcoholic cirrhosis. Then the surface will be again smooth in heart failure and hepatitis. It will be nodular in alcoholic cirrhosis. A nodular liver you may also get in metastasis. Then on palpating whether there any tenderness is there or not, you see. The tender hepatomegaly is a feature of viral hepatitis, heart failure, right heart failure, amoebic liver abscess, pyogenic liver abscess. So you will see the border, surface, tenderness, consistency, whether smooth, firm or hard. Smooth liver again you get in heart failure and hepatitis, firm you get in cirrhosis, hard you get in malignancies, hepatomas. Then you will see whether pulsatility is there in a liver. Liver pulsatility is tested by putting both the hands like this and look for the pulsatility, or even you can put a hand like this and see any pulsatility is there in liver. Liver pulsatility. The systolic pulsations of liver you get in tricuspid regurgitation, diastolic you get in tricuspid stenosis. So now this is the liver palpation. How to palpate for the spleen? Spleen, I will tell you, there are 4 methods to palpate spleen. You come from the right iliac fossa, move your hand with each expiration. With inspiration, if it is enlarged, it will come and touch. It will come and touch. This is one method for the spleen palpation. So I repeat, start from the right iliac fossa, go towards the left hypochondric region. If it is enlarged, it will come and touch your finger. The next method is, if you don't get by this, you can make him right lateral, put a hand over the rib cage and you can palpate it. Students, suppose if the conventional method, if you are not able to palpate, you make him right lateral and then from the right iliac fossa, you keep your hand behind the rib cage, start palpating from the right iliac fossa towards the costal margin. If it is enlarged, it will come and touch your finger. So I repeat, from the right iliac fossa, you move your finger towards the costal margin. If it is enlarged, it will come and touch. This is the second method, right lateral. The third method is the hooking method. So this is the one organ which you will palpate, this is one method which you will palpate from the left side of the patient, from the left side. Okay, hooking method. This is the costal margin. So hooking method, students, with your left hand, you try to insinuate your finger under the costal margin like this. Okay, this is hooking method. And a Middleton maneuver is the hooking method. What you do, and you give a pressure here posteriorly from the left side, from the rib cage you give a pressure. Hooking method from the left hand and you give a pressure posteriorly to the rib cage, so then it becomes a Middleton maneuver. Okay students, this is the third method. Then dipping method, same which I did for a liver enlargement, we can do for spleen also, dipping method. I will show it again. So a dipping method, same how you do for a liver enlargement, you dip the fluid and palpate with the finger. You palpate like that. Spleen enlargement, students, you have to distinguish it from a kidney enlargement. What are the differences? Spleen enlarges towards the right iliac fossa like this, whereas a kidney enlargement will be going towards vertically towards the left iliac region. There is one difference. Spleen has a notch, kidney don't have a notch. Kidney is a retroperitoneal organ, it doesn't move with respiration. Spleen does move with respiration. Kidney is retroperitoneal, so a band of colon, you can get resonance band of colon in a kidney swelling, but not in a splenic swelling. So what are the differences? Spleen enlarges towards the right iliac fossa. It does move with respiration, spleen. Notch will be felt. And a band of colonic resonance you see in a kidney swelling, not in a splenic swelling. Then renal angle will be dull to percuss in a kidney swelling. Where is the renal angle? So dear students, the renal angle is, this is the erector spine and see the 12th rib. The junction between that is the renal angle. So that will be dull to percuss if kidney swelling is there. Renal angle will be dull to percuss. Okay. So this is the difference between a splenic swelling and a kidney swelling. Which are the other organs you palpate? Kidney palpation. Kidney is bimanually palpable and ballotable. How do you palpate kidney bimanual palpation? You will use the both hands, okay, one left and right hand like this, and then so you use both the hands, you will keep like this, then palpate together like this. Okay, both the hands you keep, palpate together like this. Bimanually you have to palpate. You have to palpate like this in the lumbar region. And next is ballotability. What is the meaning of ballotability? By palpating the kidney, you give a sudden jerk from down. If kidney is enlarged, that will come and touch this hand. Then give a jerk from upper hand, it will come and touch the lower hand. This is ballotability. Kidney is ballotable. So how do you do ballotability? You give a jerk like this. I will show when I palpate from the left kidney ballotability. Yeah? You palpate like this, ballotability. Left kidney is palpated from the left side. I will show that. So you keep the hands like this and palpate. Okay. Bimanually palpation. Left side it is palpated, left kidney, and ballotability. Okay, you give a jerk like this. Ballotability. Then palpation of gallbladder. Gallbladder is at a junction of rectus abdominis and the 9th rib. So you palpate there. If acute cholecystitis is there, there is Murphy's sign. If you ask the patient to take a deep inspiration, he winces with the pain. सांस ले, जोर से ले. Yeah, he will winces with the pain if there is acute cholecystitis. So, liver palpation, spleen, kidney palpation, gallbladder, and abdominal aorta palpation. Abdominal aorta is palpated just 2 inches above the umbilicus. You can put your finger like this and you can palpate. Especially it is seen only in thinner individuals. It is palpated in thinner individuals. Just above the umbilicus, you can put your fingers like that. Abdominal aorta palpation. Then tenderness, rebound tenderness. So you give sudden jerk like this and look for a rebound tenderness. Rebound tenderness is a cruel way, you should not do it, as I discussed in abdominal pain. You can ask the patient just to cough, or light percussion is enough to look for a rigidity. So you getting peritonitis. Then cross tenderness. Sometimes if you press on the descending colon, you may get pain in the right McBurney's point in appendicitis. That is cross tenderness. These are the things which you look in palpation. Next, let us go to the percussion. Percussion will discuss percussion of the liver, percussion of spleen, shifting dullness, fluid thrill. Percussion of the liver. As you all know, the liver dullness is present in the fifth intercostal space. So start percussing second space, third space, fourth space. See, dull, fifth space is dull. You can make out. See, this is dull fifth space. Normally, the liver extends from fifth space to the costal margin. It is 12 to 13 centimeter span. The liver span is. Suppose if the liver is enlarged, then the percussion, dull node percussion will extend downwards, and you measure that span in mid-clavicular line. The liver span you measure in mid-clavicular line. This is one way. Or the other way is, you can percuss from low down, where there will be tympanic because of stomach. Then if you get a dull node, that is the border of the liver. So from that to the fifth space where you get the upper border, you take the span. This is liver percussion. For splenomegaly, there are three methods of percussion: Nixon method, Tropp's percussion, Castell method. Nixon method. So what you do in Nixon method is, the low border of lung resonance in the posterior axillary line. This is a posterior axillary line. From that low border of lung resonance in the posterior axillary line, you come towards the costal margin. This is the costal margin. Comes towards the costal margin. Now we'll come to the lower border of lung resonance. Yeah. So here, then from the posterior axillary line, you come towards this is a costal margin. So here I got the dullness. So from posterior axillary line, you come towards the costal margin. The distance from the costal margin to the dullness where you got should be less than 8 centimeter. If it is more than 8 centimeter, if it is towards that area dullness, then that is splenomegaly. Because spleen enlarges posteriorly. So come to a low border of lung resonance. From the posterior axillary line, start percussing towards the costal margin. Then you get a dullness at one point. That dullness point to the costal margin should be 8 centimeter. If that dullness is more than 8 centimeter, then splenomegaly. The Nixon method. Then Tropp's area. Tropp's area is 6'3" above. See, this is the second rib, third, fourth, fifth, sixth. See, 6'3" above. 6'3" above. This is a 6'3" above. Costal margin below. Costal margin below. Then mid-axillary line laterally. This is a mid-axillary line. 6'3" above. Costal margin below. Mid-axillary line laterally. This is the semilunar space. Semilunar space, Tropp's area. This is a Tropp's area, semilunar space. This is normally resonant to percuss. See? Resonant to percuss. If that becomes dull, that can be due to massive pericardial effusion, massive pleural effusion, fundal growth, splenomegaly, left lobe of liver enlargement. That becomes dull. The other way to describe the borders of trough space is right side by the left lobe of liver, left side by the spleen, above by the lung resonance, below by the costal margin. Right side by the left lobe of liver, left side by the spleen, above by the lung resonance, below by the costal margin. Which are the condition? It will be dull, splenomegaly, CS stomach, massive pericardial effusion, pleural effusion. You get Drops area dull to percuss. Which is the other way of percussion for splenomegaly? Castile method. How to do Castile method? Dear students, Castile method. Castile method, you percuss above downwards in the anterior axillary line till 8th or 9th space, and patient should take the deep inspiration. And patient taking deep inspiration, that 8th or 9th space should be resonant. If there is dullness, that indicates splenomegaly. So for a Nixon method, posterior axillary line. For a Trops percussion, you took mid axillary line, and for Castile method, you take an anterior axillary line. Okay, now anterior axillary line. This is anterior axillary line. We percuss. Start percussing. Eighth or ninth space. सांस ले. Hold करो. See, resonant. This is dull. Resonant. This is A space. सांस ले. सांस hold करो. Again resonant. With deep inspiration also resonate. If that is dull, then it is splenomegaly. So you percuss the liver, you percuss the spleen, then shifting dullness and fluid thrill. Dear students, now let us examine how to look for the shifting dullness. Fluid accumulates in a horseshoe shape, so the flanks will be dull and above will be resonant. You start percussing from the epigastric region till the umbilicus, and then from umbilicus you start percussing downwards till you get a dullness. Then make the patient left lateral, wait for 30 seconds. This dull area will become resonant because fluid will shift to the opposite side. So I will demonstrate now, just see. You start percussing from epigastric region till umbilicus, and then from umbilicus, suppose if you get dullness here, ask him to lie down left side. Bhai taraf turn kariye. Bye. Yeah, bus. So you wait for 30 seconds. The fluid will go towards that side, and you should never remove the finger. Now, because fluid has moved towards that side, this finger which was dull to percuss will become resonant. This will become resonant. Then if you want to double confirm, again make the patient right side, wait for 30 seconds, the resonant which was there will become dull to percuss. So wait for 30 seconds, now the fluid will be towards the flanks, the one which was resonant will become dull to percuss. You percuss here, this will become dull to percuss. This is shifting dullness. And next is fluid thrill. Fluid thrill is ask the patient to hold his hand in the umbilicus, then you give a percussion, and that side you can feel the thrill. I will demonstrate how to do it now. अब आपका ये हाथ है ना इस तरह, ओके, होल्ड करें, ठीक है, ठीक है. Or another third person can hold it like this, or a patient can hold it like this. Then you give a jerk like this, and you can feel the thrill if fluid thrill is there. Okay, this is fluid thrill. Okay, students. Now, one more thing which you should do in percussion is Puddle sign. For a very minimal fluid, if it is 150 ml is there, you have to do percussion in knee arm position. We will do that now, the percussion in knee arm position. Okay. So dear students, I will show how to do Puddle sign. This is the knee arm position you have to keep for a Puddle sign. The minimal fluid 150 ml will accumulate surrounding the umbilicus. Then you can percuss here near the umbilicus, you can percuss. That you will get a dull. Or the other method is you put a stethoscope from the periphery, you bring a pen, Puddle sign, you will auscultate here. Then with a pen, you bring from periphery to center. Okay. Suppose if there is a fluid accumulation, there will be a change in the intensity of the sound which you will hear. Okay. This is pedal sound. Okay. So these are the things which you see in percussion. In hydrated cyst, if three fingers, if you percuss on the middle finger, you may get vibration. The other two fingers also you may get. Okay. And developing country like India, hydrated cyst is more. These are the things which you see in percussion. Next is auscultation. What are the things you see in auscultation? Vowel sounds. Where you look for vowel sounds? Ileocecal region, the 2/3 and 1/3. The McBurney's point. You will auscultate. So McBurney's point you have to auscultate for 1 minute. The normal vowel sounds is 3 to 5 per minute. For full minute you have to auscultate 3 to 5. The vowel sounds will be absent in peritonitis and will be increased in intestinal obstruction. Then you have to look for a venous hum. Venous hum in between epigastric region and umbilicus. You get in portal hypertension due to the connection between umbilical vein and portal vein. That is known as Crewiller-Baumgarten syndrome in between epigastric region and umbilicus. You may get a bruit over a liver in hepatoma or alcoholic hepatitis. Or you have to auscultate for a rub in a perihepatitis and perisplenitis. Rub you get in infected endocarditis, CML, sickle cell anemia, and after splenic biopsy. You may get a rub over a splenic area. So this is about auscultation. So students, inspection, palpation, percussion and auscultation of abdomen. Thank you.